Happy to be here on this lovely spring day. It's actually better we're all inside today, so. And thank you to Dr. Bernstein and Rachel Broderick for inviting me and the Scleroderma Foundation. And I'm glad, well, some people are still eating, but I don't mind talking about GI stuff eating because that's my job. I hope it's okay with you guys. I'm going to be talking about some things that may sound a little gross. But I'm going to talk about GI dysmotility in scleroderma. And to remind you, esophagus is what everyone knows about, but it's way more than that. So just an introduction, scleroderma affects the GI tract, and it's actually very common in patients with scleroderma. 90% have GI involvement of some sort. Not everyone's symptomatic of it, but about 50% are. There was a study that said 70% of patients develop GI symptoms within 1 year of developing Raynaud's, so again, pretty common. And it can affect any part of the GI tract from the mouth to the anus, though the esophagus is the most common, 50 to 80% of patients. The cause of GI dysfunction is multifactorial, but initially the thought is that the effects of the scleroderma on the microvasculature of the GI organs leads to effects on the GI nerves. And then when the GI nerves are affected, you have issues with movement and secretion of the organs. And then ultimately, the muscle of the organs are affected, which can lead to scar tissue of the muscles. And then once the muscles of the GI tract are affected, then it's difficult for it to do its job in squeezing, moving, absorbing, etc. So this might be a little bit too dumbed down, but just I wanted to introduce you to the GI tract in general in case you don't know what every part of the GI tract does. So essentially, the GI tract is a long continuous tube. It's almost like it's our plumbing system of the body. But each organ within the GI tract kind of has a different function. And the function is related to its ability to contract, to relax, to secrete fluids, and to absorb fluids. So starting from the top down, what's circled is called the oropharyngeal segment of the GI tract, a little bit above where I usually work. But that includes the teeth, salivary glands, tongue, and the back of the throat, the hypopharynx. And obviously, the digestion begins with chewing the food, secreting amylase from your salivary glands, which starts breaking down the food. And then, from my standpoint, what's the most important is it's the back of the throat's ability to transfer the food into the esophagus. Then comes the esophagus. And essentially, the esophagus is a tube that transfers the food that's partially broken down into the stomach. It also has two sphincters, so the upper esophageal sphincter and the lower esophageal sphincter, which serve as barriers. So the lower esophageal sphincter is a muscle at the bottom of the tube that acts as a barrier to prevent reflux. Otherwise, anything in your food in your stomach might come back up. Next comes the stomach. So the stomach is an organ basically that mixes and grinds kind of like a blender, and it breaks down the food to very small particles, to 2-millimeter particles. And then its job is to transfer those little particles into the small bowel so that our nutrients can actually be absorbed. So the stomach itself does not absorb any nutrients. It's really just breaking it down and then dumping it into the intestine. Next comes the small intestine. So the small intestine is actually about 15 feet, but it's all jumbled within the middle of our abdomen. And what it does is it absorbs our nutrients and vitamins. It secretes fluid, but it also absorbs fluid. And then its job is to transfer the food into the large intestine. So by movement of squeezing, relaxing, it kind of propels the food forward into the colon. And the colon is also called the large intestine. That comes next. It's also a few feet long. It wraps around from the right to the left of our body. And what its job is to, now all the nutrients are taken out of the food, it has to, the stuff that hasn't been absorbed and is kind of waste has to get solidified to exit our body. So the colon really absorbs a lot of water. It doesn't really absorb any of the nutrients, but it absorbs water so that the waste becomes more solid. The colon is really also the host of our, where the majority of our bacteria are within our gut. So it's normal for our gut to have a lot of bacteria, but it's mostly in the colon. That's a whole separate lecture on what the microbiome or bacteria does. But they also do help, has a lot of jobs, but I guess in the colon, the most important is that it also helps break down some of the waste that's there to create what's called fatty acids. And then finally, the colon has to transfer this waste, which is now called stool, into the rectum. And then the rectum sits at the bottom of the colon. Its job is to store the waste until it's time for us to go to the bathroom, or it's socially appropriate to go to the bathroom. And then the waste exits our anal sphincter, and then there it is. So that's the journey of the GI tract. So how does scleroderma affect the GI tract? We're again starting at the top. So oropharyngeal involvement is actually more rare, but the skin tightening around the mouth can actually cause problems chewing because the limitations of opening the mouth. Many patients with scleroderma might have Sjogren's disease, which also causes decreased saliva and dry mouth, which can lead to the sensation that food is sticking in the back of the throat. And then the actual muscles of the back of the throat can be affected, although, as I said, it's less common. But then you might get difficulty propelling the food into the esophagus, so it might be going into the wrong tube. It might actually cause aspiration and into the lungs. Let's move on to the esophagus. It's my favorite organ of the GI tract. Scleroderma esophagus is very, very common. So 50 to 80% of patients have esophageal involvement. As I said, not everyone has symptoms from this, but if you do testing, you'll see that they have involvement. The classic picture of a scleroderma esophagus is that the body, the tube part of the esophagus doesn't move or doesn't contract. That's called aperistalsis. And that the bottom muscle, the lower esophageal sphincter, is very loose. So that's called hypotensive LES. And the lack of contractions leads to an inability to clear and propel the food into the stomach. Gravity is still around, so of course things will still go down with gravity. But the bottom muscle being loose is a setup for patients to develop gastroesophageal reflux disease, or GERD. So the symptoms of this would include dysphagia, which is food or liquid feeling stuck or sluggish going down the esophagus. Regurgitation, where things that haven't really reached the stomach can come back up. That can also be seen in GERD. So if it does go to the stomach but it comes back up, you feel that either liquid or food kind of going back up into your throat. And then you can get heartburn. So gastroesophageal reflux disease is defined when there's reflux of stomach contents or acid that goes up into the esophagus. The classic symptoms are esophageal, so as I mentioned, heartburn, regurgitation, or chest pain. There are some extra esophageal symptoms that can be attributed to GERD, although it's a little bit controversial because when someone has these extra esophageal symptoms like sore throat, I mean, there are many causes of sore throat, so it's hard to attribute it to the reflux, but that is one of the manifestations. The exposure of acid into the esophagus can eventually lead to stricture, so scar tissue of the bottom of the esophagus, which is then another cause of food getting stuck in the esophagus, not just the motility, but a structural narrowing there. Thankfully, reflux can be well controlled, but there are some complications of GERD we need to be aware of. Some patients will get esophagitis or inflammation of the esophagus from the reflux coming up. Some patients will get Barrett's esophagus. Thankfully, only 10% of patients with reflux altogether will get Barrett's. It is more common in males versus females. But the reason we care about Barrett's is a condition where the cells of the bottom of the esophagus kind of morph to look more like stomach cells. So they become, the way they look on the endoscopy are more like stomach cells. And the reason is it's thought to be a protective mechanism against the acid. And it doesn't actually cause symptoms, but the reason we care about it is it's a precancerous condition. It's a risk factor for developing cancer. So esophageal cancer or adenocarcinoma is a risk factor of GERD. Thankfully, very few patients with Barrett's will develop cancer, less than 0.5% a year, but it's still a risk, so we have to keep an eye on it. So I'm going to just walk through some diagnostic tests that scleroderma patients may go through to investigate their esophagus symptoms. So an EGD, or esophagogastroduodenoscopy, is basically a scope where we go in with a tube with a camera to take a look at the esophagus, stomach, and small intestine. Patients, actually, you can do it awake, but most patients want to be asleep for this, so we give IV anesthesia. It's not the same as a surgery where you're totally knocked out, but it's enough to be comfortable. And an EGD doesn't really tell us much about the movement of the esophagus or how it's working, but it can be helpful for ruling out complications of GERD. So on the left is I can use my pointer. This is a normal esophagus. The middle is esophagitis, or inflammation of the esophagus. And this is Barrett's esophagus, where it looks like tongues of salmon-colored mucosa. A barium swallow is sometimes ordered. This gives, basically, it's where the patient swallows some contrast and then get an x-ray studied while it's going down the esophagus. This gives you an outline of the esophagus for structural findings or inflammation. May also give you some information about motility. If the contrast is sitting in the esophagus for many minutes, that's not supposed to happen. I typically don't do this as my first step because I'm a gastroenterologist, so I do scopes. But it is useful to me if I think that the patient's too high risk to undergo anesthesia. Esophageal manometry is the gold standard to really look at the motility of the esophagus. It's not the most pleasant test, but it's very helpful. Basically, it's a probe that's placed down the nose and into the esophagus when the patient is awake. We do use topical lidocaine for the nose, but really the patient has to be awake because it's an interactive test where you swallow, and then we look at the pressure of the esophagus while you're swallowing. So the data of that information gets displayed as pretty colors. On the left is On the left is a normal swallow. So the color is showing that the esophagus is squeezing, and it's squeezing as from the top to the bottom in a sequential manner. On the right is actually one of my patients with scleroderma. You can see really nothing's happening. There's a swallow at the top, but then the body of the esophagus is not doing anything. And furthermore, this lower esophageal sphincter pressure is really not there. It's hypotensive or very loose. Sometimes we might also do reflux testing for patients with scleroderma. If you see esophagitis on an endoscopy, we already know you have reflux, so we really don't have to do reflux testing. But 70% of patients with GERD actually have a normal endoscopy, so you may need to do reflux testing to prove if you have GERD or not. There's two ways to do this. You can do another probe-based test, which is a much smaller probe in the nose into the esophagus that you go home with, and it measures reflux, both acid and non-acid. So the advantage of this is it measures all kinds of reflux, not just acid reflux, and it's non-invasive. You don't need anesthesia, though not particularly pleasant. The other way to do reflux testing is wireless. This is actually placed during an endoscopy. You place a little chip called, the brand name's called Bravo, and it gets suctioned onto the bottom of the esophagus, and it stays there until it just falls off on its own. And then you go home with a monitor, and the monitor measures how much acid is coming into the esophagus. So it's a lot more comfortable than the probe-based test, and it gives you slightly more longer information because you can measure up to 48 hours. The disadvantage is it's only measuring acid, so you have to be off medication, any acid medication to do it. And of course, it requires a procedure, endoscopy and sedation. So how about the treatment for esophageal symptoms? I spelled symptoms wrong. So for dysphagia, if we do find a stricture or narrowing in the bottom of the esophagus, we can stretch it open and do a dilation while we're in there. Unfortunately, there really is no medication available that helps with the complete aperistalsis of the esophagus, so you need to do lifestyle modification. You have to make sure you're sitting upright when you eat, let gravity do its trick, take small bites, chew very thoroughly, sometimes chasing the solid food or dry food with some water to help it go down. Sometimes we use a medication called bethanechol, which is actually not made for the GI tract, it's made for the bladder. It helps with urinary retention, but it squeezes the smooth muscle of the bladder and also the esophagus. So sometimes I'll use that if someone has very weak motility, but not complete lack of motility. I've had kind of mixed results with that, but sometimes we use it. In terms of the reflux, we do, there are many ways to treat reflux: dietary, lifestyle modification, over-the-counter medications, and proton pump inhibitors. So in terms of dietary changes, food can trigger reflux in several mechanisms. One is that there are certain foods that relax the lower esophageal sphincter even more. Some of the common ones that have been pointed to is caffeine, chocolate, alcohol, mint, all the good things in life. Spicy food, tobacco, not a good thing in life, and citrus. Food can also trigger reflux by just staying in the stomach for longer. So possible triggers for this would be oily foods, fatty foods, and large meals that just sit in the stomach for longer, and then more chance for it to come up. So that being said, with all the things that I just mentioned, the trials looking at dietary modification for reflux are very small or are lacking. So I really hate to limit people to the good things in life. So I do tell patients to take a food diary to see what triggers them to get reflux, so that you're not really changing your quality of life for something that might not help anyway. It is important to wait several hours after eating to then lay down at night to go to sleep, especially when you have stomach involvement, which I'll talk about in a bit. You don't want the food or liquid to come up in the middle of the night while you're sleeping and go up into your lungs to cause a pneumonia. So avoiding late night meals, heavy dinners, and then some patients find that elevating the head of the bed or using multiple pillows are helpful, and that actually has been studied in patients who get nocturnal reflux. It has been helpful to do that. And then in someone who's overweight, actually losing weight can help decrease reflux as well. So the treatment in terms of medication, so there are many over-the-counter meds. I think the GI aisle in the pharmacy is one of the biggest aisles. There's Tums, Gaviscon, Alka-Seltzer. These all can help on demand. So if you're getting heartburn, you can pop one in, and it might neutralize the acid once it's already been produced. It's very short acting, but it's quick acting. The next class up, the next step up is H2 blockers or antihistamines. They partially shut off the acid production, so they work on the cells of the gut of the stomach that produce acid. These are things like ranitidine, famotidine. They do last longer than the over-the-counter medications, and they're all pretty quick acting as well. But the mainstay of treatment for reflux are a class called proton pump inhibitors. So they really have revolutionized how we treat reflux, because they work very, very well to shut off the acid. So these medications basically shut off the acid pumps of the stomach almost 100%. They are more effective in studies to treat esophagitis and reflux than the H2 blockers. There are 7 PPIs now in existence. 4 of these are also available over the counter, but note that the over-the-counter dose is actually smaller than the prescription dose. So if the over-the-counter dose is not doing it, don't say, well, this doesn't work for me. You might actually need the full strength of it. And some patients, especially with scleroderma, need twice-a-day dosing, whereas usually we do it once a day. All of these, except for the dexlansoprazole, need to be taken 20 to 30 minutes before a meal. I tell patients to do before the biggest meal of their day. So it's typically before breakfast, but let's say you're getting heartburn in the evening time, then I might say, well, then take it before dinner time. It does need to reach a steady state in your body, so it's not really the type of medication you can take as soon as you get heartburn, you pop a PPI. No, it actually, you have to take it regularly for it to be the most effective. Now, oh, that picture shrunk down. That's a newspaper. You've probably seen in the news, there have been many, many articles about whether these PPIs are safe. So in the last few years, some articles have come out linking chronic high-dose PPI use to various conditions. The thing to note about these studies is that they're studies looking backwards at big groups of patients, and they compare the patients who are on PPI with patients who are not on PPI. And then they say, well, does the PPI group have a higher risk of X, Y, or Z? So one thing to note is when you look backwards at big groups of people, you're not really controlling for other variables that might lead to that outcome. It's also important to notice that correlation does not equal causation. So just because you see an association doesn't mean the PPI is what's doing it. And then even if you believe that all those risks are real, the absolute risk per patient is actually quite small. So these are just some risks that have been in the literature in the last few years: hip fracture, osteoporosis, chronic kidney disease, dementia. The dementia study actually had major flaws. They didn't, the group that had more dementia, they didn't look at whether the patients had a family history of dementia, which is a clear risk factor. And actually a more recent study came out looking forward prospectively that did not show a risk of dementia. C. diff infection is actually probably a real risk of PPI. It's a stool infection that can be quite serious if it's not picked up or treated. So the long story short is, are PPI safe? They probably are. in patients who don't really need a PPI, of course, we try to get them off of PPI. If there are real indications for PPI, so that includes esophagitis, GERD, Barretts, then we really weigh the risk and the benefit. And there are even studies to suggest that when you're on a PPI and you have Barrett's esophagus, you can actually decrease the progression to cancer, which I would say is a pretty good outcome. So if medications cause side effects or patients don't want to be on medications, we can do surgery for reflux. It's called a fundoplication, where essentially they wrap the top of the stomach around the bottom of the esophagus, creating that barrier that's missing in scleroderma. But there are very few studies in fundoplication in scleroderma patients. The small studies that are there probably show that it's safe. But the reason why we might avoid it is because if your esophagus doesn't really contract, and now you're putting a barrier at the bottom, an extra barrier, that dysphagia sensations might be worse. So we definitely do an esophageal manometry prior to any fundoplication to make sure that that's not a contraindication. All right, so moving on to the esophagus, next up is the stomach. So the motility disorder that scleroderma patients might get in the stomach is called gastroparesis. It is one of the causes of gastroparesis, and it's a syndrome of delay of stomach emptying. So remember I said it churns up the food and then empties it into the small bowel. In gastroparesis, there's a delay in that. So the symptoms of that could be pain at the top of the stomach, nausea, vomiting, fullness, and bloating. There are two diagnostic tests that we really do to make the diagnosis. One is called a gastric emptying study, which is where you go to the nuclear medicine department, you eat a meal of scrambled eggs and toast that has some stuff labeled in there, and you eat the meal, and they take pictures up to 4 hours. And at the end of 4 hours, if more than 10% of that meal is still in your stomach, that's considered delayed. There's another study called the wireless motility study, Smart Pill is the brand name, where you swallow a really big shaped sensor that measures pH, pressure, and temperature. And you go home with a monitor and it just goes along your GI tract. And when we analyze it, I can tell how long was it sitting in your stomach, how long in your small bowel, and how long in your colon. It is done in only limited centers. We do the Smart Pill here. I would say the Smart Pill is more helpful in patients with scleroderma who might have whole GI involvement, not just stomach. So the treatment of gastroparesis, kind of like GERD, there are some dietary lifestyle modifications, pharmacologic treatments, some procedures, and nutrition access. So the dietary changes are based on the fact that different nutrient contents will empty at different rates. So on this graph, you can see that just pure water or sugar water empties pretty quickly exponentially. Fluid, like high-calorie liquid, like Ensure or some other supplement, empties at a linear rate, and then solids are first lagged and then eventually will empty. So if you're having a hard time eating a lot of solid food, especially when it's high fat, we might tell you to try to increase your good liquids. Obviously, we don't want you to chug soda or other things that don't have good nutritional value, but these supplements or smoothies or things like that might be helpful. There are a host of medications that we can use to treat gastroparesis. None of them will make the gastroparesis go away, but they can help manage the symptoms. The first column are anti-nausea medications. You can see there's a ton of them out there. The middle column are prokinetics, so they actually try to accelerate the gastric emptying. There are only two available in the US, metoclopramide or Reglan, and erythromycin. So Reglan or metoclopramide can help with both nausea and promote stomach motility. The problem is there are some neurological side effects and people get twitches. And then more serious is after long-term use, after 12 weeks, there's a higher risk of what's called tardive dyskinesia, which is an irreversible movement disorder that I'm very afraid to give to my patients. So I really try to avoid using metoclopramide for long-term. Erythromycin is an antibiotic, but it actually has pro-motility properties. So that's something else we use. Cisapride is a medication that was taken off the market. I should probably just take it off my slide because it was causing cardiac arrhythmias, so that's no longer available. Domperidone or Motilium is a medication similar to Reglan but doesn't have that neurological side effect. It's not FDA approved in the US and it probably never will be, but we can get it in other ways, and I use this quite frequently. Finally, for the pain aspect of gastroparesis, we can use certain neuromodulators like antidepressants that actually work on nerve pain. The last one I want to mention, mirtazapine, it's an antidepressant that has been studied in gastroparesis, but I find particularly helpful in patients who need to stimulate their appetite or who are underweight, because it really can help with that. There are a few procedures we can do for gastroparesis. You might have heard about endoscopy with Botox. So back in the, I think, 90s, early 2000s, there was a lot of excitement about injecting the pylorus muscle, which is the bottom muscle of the stomach, with Botox. It helps relax that muscle, so then you think, okay, maybe food will go down more passively and will be easier. When they did the randomized controlled trials, though, they found it was not better than placebo or saline injection. But guess how many patients were in that trial? 20 patients. So I still do it. I tell patients straight up, the evidence isn't there, but when you've exhausted other medications and you're really desperate to try something, there's really little harm, although it is an endoscopy. For those who do well with the Botox, and for those who it works well on, it seems to be amazing. We can do something a little bit more permanent called G-POEM, which I won't get into, but Botox, as you all know, is temporary. So even if it works, it's not going to last more than a few months. Finally, there's something called a gastric stimulator, which we actually don't do at Columbia. Maybe one day we will. There's a few centers in New York that do it. Basically, it's almost like a pacemaker of the stomach that helps, it emits energy into the stomach to help promote the movement. I do have concerns in scleroderma patients about wound healing and infection, because it is a foreign object implanted in your abdomen, especially if you have skin involvement of the abdomen. Finally, nutrition. So in very severe cases of gastroparesis and small bowel motility, which I'll talk about next, we might need to help the patient get more nutrition if they're unable to take everything by mouth. So sometimes we do a feeding tube to help maintain proper weight. Obviously, if we put a feeding tube into the stomach and you have severe gastroparesis, that's going to come up, or patient might vomit it. So we actually put a tube into the stomach and then a smaller tube below that into the jejunum or small bowel. So the nutrients are getting delivered straight to the small intestine and can kind of bypass the stomach. We also can use this, patients can vent the tube in the stomach. If they're feeling nauseous, they can kind of open the tube and let out air or liquid. That can make them feel a little better. The risk of a feeding tube in anyone is infection and bleeding. In scleroderma, I would add wound healing, again, is an issue. I kind of got traumatized when I was a fellow. I saw a patient with scleroderma with a feeding tube who had horrible wound healing, so I kind of avoided doing that for a while, but in the appropriate patient, it can be very helpful. I will say I want to go back to nutrition. I don't have a slide on it, but in very severe cases of gastroparesis, but also small bowel scleroderma, we might need to do what's called TPN, total parenteral nutrition. And it's when your gut's really not working that well, but you need to get the nutrients in there. We do a peripheral IV, a kind of specific IV to put the nutrition in the vein. It's not, has its own risks, so we really do it on patients who we can't get them better nutritionally with the other ways we try. I won't talk much about GAVE. I forgot to put a picture there, but Dr. Bernstein thankfully had a picture. GAVE is called watermelon stomach, and basically it's because it looks like stripes of red on the bottom part of the stomach. And these are vascular changes that can lead to chronic oozing. So it doesn't cause symptoms per se in terms of like abdominal pain or nausea, vomiting, but it can cause GI bleeding, usually slow bleeding, not that you're massively bleeding out, but enough that you might see dark stool, you might get iron deficiency and no clear reason why. Thankfully, it is pretty easily treated with an endoscopic procedure where we kind of buzz the blood vessels, like cauterize them. All right, so moving on to the small intestine. So the scleroderma small bowel disease, there are several ways it can affect the small bowel. One is, like the stomach, it can cause slow motility. But there are also structural changes that can then have other implications. or impact. So the small bowel can get quite dilated or distended, and the folds can get closely packed together. So this is a picture on the left of a normal radiology test called a small bowel series, where the patient, again, drinks contrast and you follow the contrast going down. But on the right is the same thing in a scleroderma patient. You can see the diameter of the small bowel is much larger. It got kind of stretched out. You can also get something called small bowel diverticulum, which are little outpouchings or pockets of the small bowel. It's actually very common to have that in the colon after anyone age 50 is, with every decade of life, you get more and more patients who have it, and they're usually asymptomatic. But in the small bowel, it's a lot more rare, and patients with scleroderma can get it. Because of these structural changes, you can then develop SIBO, or small intestinal bacterial overgrowth. So scleroderma's effect on the motility and the structure leads to several symptoms. You can get abdominal distension, even visible distension, bloating or discomfort or fullness after eating. You can actually develop obstruction symptoms as if you have a blockage. You go to the ER, nausea, vomiting, abdominal pain, and you take an x-ray or a CAT scan. It looks like an obstruction, but it's not. It's called pseudo-obstruction. It's just because of the way the bowel looks. In severe cases of small bowel disease, you can also get malabsorption, so you can get vitamin deficiency, weight loss. You can get fat malabsorption, which then leads to diarrhea, which might be oily looking, and weight loss. And then again, the SIBO, which I'll talk about. So SIBO is quite common in scleroderma patients. The reason they get patients with scleroderma might get SIBO is because of the slow movement through the bowel, plus this dilated bowel are risk factors. And I tell patients, imagine a nice stream that has clean water, it's flowing nicely, it's clear, you can see through it. Then imagine a pond that's just sitting there, and then you imagine all that scummy green stuff on top. So that's kind of what the bacteria is like in the bowel. I mentioned it's normal to have a lot of bacteria in the colon, but when it overgrows in the small bowel, that leads to symptoms and other issues. So we define it by 10 to the 5th bacteria per milliliter in the fluid of the jejunum. So the way we used to diagnose this is we go in with a scope all the way down, more than just an EGD, we have to go farther down, aspirate the fluid and send it to the lab. Obviously that's very invasive. I haven't done that since my fellowship because we have other non-invasive ways to test it. So this is the hydrogen breath test. So hydrogen breath test is where the patient comes in, takes some non-absorbable sugar, it goes down your GI tract. When it hits bacteria, the bacteria see it because it's food, start to ferment it and create these gases. They'll create hydrogen and methane. Those gases get absorbed into the bloodstream and then into the lungs, and then when you breathe it out, you can actually measure it. Oh, my picture got shrunk again. Essentially, in someone without SIBO, you're going to get a flat line, flat line, flat line, and then when it hits the colon, a peak, and that's normal. And someone has small intestinal bacterial overgrowth, you might get a flat line, a peak when it gets to the small bowel, and then another peak in the colon. So that's how you define a positive test. Frankly, though, in scleroderma patients who have the risk factors, I just kind of assume they have SIBO and treat them as if they have SIBO without doing the test. So the consequence of SIBO is that the bacteria in severe cases can compete with nutrients. They also break down the bile acids that are in your gut that make them ineffective. So that can lead to fat malabsorption because the bile acids are what help you digest or break down fats. In very severe cases, the bacteria can actually cause physical damage to the lining of the small bowel where our absorption takes place, so then you get malabsorption because of that. And then obviously can lead to many bothersome symptoms: bloating, diarrhea, weight loss, and malnutrition. Thankfully, we can treat SIBO. We usually use rotating antibiotics. So the one we use the most now is called rifaximin because it's a GI-specific antibiotic, so it probably doesn't lead to other resistance pattern in the rest of your body. But there are many different types of antibiotics that we use, and we tend to rotate it so that the bacteria don't get used to seeing the same antibiotic over and over again, so they don't breed resistance. We can also use pro-motility medications to help promote the movement through the gut to help so that the SIBO doesn't come back. Some patients ask me about if there's a diet they can do to help with SIBO, and if you read online, there's going to be a lot of diets saying avoid all sugar, and because that'll feed the gut, that'll feed the bacteria. And I think in theory that does make sense. I don't think there's been a really good study looking at that. But in someone who might be malnourished already, I really hate to limit their diet even more, so I tend not to give this to everyone, but that is something that comes up. Finally, we can use something called octreotide, which I'm going to talk about because it has been studied in scleroderma patients, specifically in those with SIBO. So octreotide or somatostatin is a hormone that's present within the GI tract. The synthetic version is octreotide. And although in high doses it actually decreases motility, in a low dose, it's been shown to actually induce the motility of the small bowel. So this is just a picture from the New England Journal article back in the 90s when they studied this. And you can see they did a test called antroduodenal manometry, which is a pretty invasive motility test. Many centers do not do this. But this is a patient without scleroderma. This is the normal motility pattern of the contractions of the small bowel. When they give the low-dose octreotide, that motility increases. Here's a patient with scleroderma. They have no motility, no contractions of the small bowel, but after they gave the low dose of octreotide, that increased their motility. And then they looked at the symptoms as well, and before and after octreotide, they found decreases in pain, nausea, and bloating. I didn't put the graph up, but also it decreased their incidence of bacterial overgrowth, which makes sense. Again, if you're moving things through better, you're less likely to get that overgrowth. So moving on to the large intestine and the rectum. So lower GI symptoms are actually the second most common cause of symptoms after the esophagus. I don't have a specific slide on constipation, but patients obviously can develop slow motility of their large bowel. And the more slow it is, the more time there is for the colon to extract that water out of the waste. So stool and look, I'm glad no one's eating anymore, but stool can then get much more hard, small, and infrequent bowel movements. And thankfully, there are many medications out there available for constipation. I don't have a slide specifically for that, though. We talked a little bit about diarrhea already. That can be from SIBO. It can also be from malabsorption issues with the small bowel. But I think probably a very important symptom that people might not talk about is fecal incontinence. And I did want to talk about that because it's a really huge contributor to lower quality of life in patients. And it's likely underreported because it is an embarrassing thing to bring up to your doctor. The causes of fecal incontinence in scleroderma is multifactorial. Obviously, scleroderma can affect the nerves of the gut, so you can get a neuropathy where you might not feel the stool that's in the rectum ready to go, so things can spill over. You don't get that urge to have a bowel movement, it just comes out. You can also get thinning of the anal sphincter, just like you get changes in the skin. You can get changes in the sphincter, which will then make it weak. And the sphincters really are a way of maintaining continence. It's tonically, when we're sitting here, it's actually tight and closed off. When it's time to go to the bathroom, we go to the bathroom and then we push and it relaxes. But if you have thinning of that sphincter where it's loose, things can come out without you getting that, without realizing. So that's called passive incontinence. You can also get thinning of the external sphincter, which is really involved in that voluntary squeezing. So let's say you have an urge, you're, uh-oh, I have to go. You squeeze voluntarily and then run to the bathroom. If you have weak external sphincter, you might get what's called urge incontinence, where you know it's about to happen and it happens. Finally, if stool is liquid, it's much easier for it to just come out. So obviously treating the diarrhea is important. There are some diagnostic tests. The first thing is usually a digital rectal exam in the office where we can kind of, first of all, look to make sure there's nothing like hemorrhoids or something else that can contribute to incontinence, but also we can assess the squeeze and the tone. If we're being more academic about it, we do an anal rectal manometry. Similar to the esophagus, it measures pressures of the rectum and anus. And it's done again while patient's awake. A probe is inserted in the rectum. The nurse or doctor who does it will ask the patient to squeeze, to bear down, and we see what's happening with that sphincter. We can also measure the sensation to see whether the sensation of the rectum is altered. The treatment is first, we have to make sure we're dealing with the diarrhea. So we treat the SIBO. We can get anti-diarrheal medications like Imodium or Lomotil. We use insoluble fiber to help bulk up the stool. So there's two types of fiber, soluble and insoluble. Most foods that have fiber have a combination of both, and even most supplements have a combination of both. But the one we want for fecal incontinence is insoluble because it bulks up the stool. There's also a therapy called biofeedback, which is like a physical therapy. I tell patients, if you need to strengthen your legs, you go to a physical therapist. If you need to strengthen your butt, you can do that too. And that can help probably more with that urge incontinence, not so much the resting incontinence. And finally, in severe cases, we can do what's called sacral nerve stimulation, which is a stimulator. It's actually approved for both urinary and fecal incontinence. And that's done with a surgeon. So to summarize, scleroderma can affect the entire GI tract from mouth to anus. The most common GI organ is the esophagus, followed by the anal rectum. GI manifestations really do contribute to poor quality of life. And I think what I notice is that a lot of patients with scleroderma with advanced lung disease or other major organ involvement kind of ignore the GI stuff because they're like, well, no one really wants to hear about that. But we do want to hear about it. Don't ignore it. Because there are a variety of medications and treatments that can help improve symptoms. Unfortunately, there's no medication specifically for the scleroderma, but the motility issues that develop because of the scleroderma we can try to treat. Thank you.